During a code, the defibrillator fails to deliver a shock after charging. What is your next immediate action? A. Resume chest compressions while troubleshooting. B. Replace the defibrillator before resuming compressions. C. Administer epinephrine immediately. D. Switch team leader before continuing. Answer A. The most important ACLS principle is minimizing interruptions in chest compressions. Even if the defibrillator malfunctions, compressions must be resumed immediately while the team troubleshoots or replaces equipment. Any pause delays perfusion and worsens patient outcomes. A patient in the ICU develops pulseless VT. After the first shock and immediate CPR, the rhythm remains unchanged. What is the next step? A. Administer amiodarone. B. Administer epinephrine. C. Deliver a second shock. D. Insert advanced airway. Answer C. ACLS algorithms stress early defibrillation for VF/pulseless VT. If the rhythm persists after the first shock, CPR is resumed for 2 minutes and a second shock is delivered as soon as the defibrillator is ready. Drugs are introduced after subsequent cycles, not before the second shock. Which of the following is an indicator that an advanced airway is improperly placed? A. End tidal CO2 of 38 mm of mercury. B. Chest rise and fall with each ventilation. C. Gastric distension with absent capnography waveform. D. SpO2 improving with ventilation. Answer C. Proper placement is confirmed with continuous waveform capnography and bilateral chest rise. Gastric distension without a capnography waveform strongly suggests esophageal intubation. Reliance on chest movement alone is not reliable, as air may be entering the stomach instead of the lungs. In bradycardia management, transcutaneous pacing is indicated when A. The patient is hypertensive and stable. B. The patient has chest discomfort and hypotension. C. The patient's heart rate is 50 but asymptomatic. D. The patient improves with oxygen only. Answer B. Symptomatic bradycardia, with hypotension, chest pain, altered mental status, or shock, that does not respond to atropine requires pacing. Pacing helps restore adequate cardiac output until a more permanent solution can be applied. During post-cardiac arrest care, which PaCO2 range is recommended to optimize neurologic outcome? A. 10 to 15 mm of mercury. B. 25 to 30 mm of mercury. C. 35 to 45 mm of mercury. D. 55 to 65 mm of mercury. Answer C. The goal after ROSC is to maintain normocapnia. Low PaCO2 leads to cerebral vasoconstriction, reducing brain perfusion, while high PaCO2 causes acidosis and cerebral swelling. Both extremes worsen outcomes, so 35 to 45 mm of mercury is the safe target. A patient has ROSC but remains comatose. Which therapy improves survival and neurologic recovery? A. High-dose steroids. B. Therapeutic hypothermia or targeted temperature management. C. Immediate coronary angiography only. D. Continuous hyperventilation. Answer B. Targeted temperature management, 32 to 36 degrees Celsius for at least 24 hours, reduces neurologic injury by slowing metabolic processes and inflammation. This is a critical part of post-cardiac arrest care in comatose patients and is supported by strong evidence. Which rhythm is most likely to deteriorate into pulseless VT if untreated? A. Sinus tachycardia. B. Atrial fibrillation. C. Monomorphic ventricular tachycardia with pulse. D. Mobitz type I AV block. Answer C. Ventricular tachycardia, even if initially with a pulse, is unstable and has a high likelihood of degenerating into pulseless VT or VF. Early recognition and treatment, antiarrhythmics or cardioversion, are essential to prevent sudden arrest. In an ACLS scenario, the team leader suddenly becomes unresponsive. What is the correct action? A. Pause resuscitation until leadership is reassigned. B. Continue current tasks while another member takes command. C. Stop drugs and continue compressions only. D. End the code immediately. Answer B. Team dynamics in ACLS emphasize seamless leadership transitions. The team cannot pause resuscitation. Instead, another qualified member assumes command instantly while others continue their roles without interruption. A patient in narrow complex tachycardia at 180 bpm becomes unstable. What is the treatment of choice? A. Adenosine 6 mg 4 push. B. Immediate synchronized cardioversion. C. 4-diltiazem. D. Carotid massage. Answer B. In ACLS, unstable tachycardia is always managed with immediate synchronized cardioversion, regardless of the rhythm mechanism. Drugs and vagal maneuvers are reserved for stable patients only. During CPR, end tidal CO2 suddenly rises from 12 mm of mercury to 40 mm of mercury. What does this indicate? A. Epinephrine overdose. B. Pulmonary embolism. C. Return of spontaneous circulation. D. Equipment malfunction. Answer C. A sudden increase in EtCO2 is a strong physiologic marker of ROSC. This occurs because spontaneous circulation rapidly improves perfusion and CO2 transport to the lungs, creating a noticeable jump in measured EtCO2. Which of the following is the best method to confirm ET tube placement in ACLS? A. Bilateral chest rise only. B. Condensation in the tube. C. Continuous waveform capnography. D. Pulse oximetry reading. Answer C. Waveform capnography is the most reliable method of confirming and monitoring ET tube placement. Chest rise and condensation can be misleading, and pulse oximetry is delayed in response. In adult cardiac arrest, what is the ideal compression to ventilation ratio when no advanced airway is in place? A. 15:2. B. 30:2. C. 5:1. D. Continuous compressions without breaths. Answer B. For adults, 30 compressions followed by 2 breaths provides the best balance of circulation and ventilation when only basic airway support is being used. During synchronized cardioversion, what precaution must be ensured? A. Oxygen must be increased to 100%. B. Shock must be delivered during the T-wave. C. The sync button must be activated. D. Chest compressions must stop permanently. Answer C. Cardioversion must synchronize with the R wave to avoid delivering a shock during repolarization, T wave, which could induce VF. Activating the sync function is critical for safety. Which drug is no longer recommended in ACLS for routine use in cardiac arrest? A. Amiodarone. B. Atropine in asystole. C. Epinephrine. D. Lidocaine as an alternative. Answer B. Atropine was previously used for asystole but is no longer recommended in ACLS guidelines due to lack of proven benefit. Epinephrine and amiodarone remain in use. A patient in cardiac arrest is found to have severe hypokalemia as the likely cause. What is the preferred treatment? A. Sodium bicarbonate 4. B. Magnesium sulfate 4. C. Potassium replacement 4. D. Amiodarone 4. Answer C. Severe hypokalemia is a reversible cause of cardiac arrest, one of the H's. Intravenous potassium replacement is critical to restore membrane stability and allow effective cardiac function. During cardiac arrest, what is the role of intravenous calcium? A. Routine drug for all arrests. B. Indicated in hyperkalemia or calcium channel blocker overdose. C. Replaces magnesium in torsades. D. Improves chest compression effectiveness. Answer: B. Calcium is not a routine arrest drug. It is used in specific cases like severe hyperkalemia, hypocalcemia, or calcium channel blocker toxicity to stabilize myocardial contraction. Which of the following EtCO2 values during CPR suggests poor chest compression quality? A. 10 mm of mercury. B. 25 mm of mercury. C. 35 mm of mercury. D. 40 mm of mercury. Answer: A. EtCO2 less than 10 mm of mercury during CPR indicates inadequate perfusion and poor compressions. Higher values suggest more effective chest compressions and better perfusion. What is the preferred route for epinephrine if 4/IO access is unavailable during cardiac arrest? A. Intracardiac. B. Endotracheal. C. Subcutaneous. D. Intramuscular. Answer: B. Endotracheal administration is an acceptable alternative when 4/IO access is not available, although 4/IO is strongly preferred for reliable absorption. Which H's and T's cause of arrest is most often linked with pulseless electrical activity, PA? A. Hypothermia. B. Thrombosis, coronary. C. Tension pneumothorax. D. Hypovolemia. Answer: D. Severe hypovolemia is the most common reversible cause of PA. The heart may generate electrical activity, but without enough circulating volume, no pulse is produced. When administering amiodarone during cardiac arrest, what is the initial 4/IO dose? A. 150 mg. B. 300 mg. C. 1 mg per kilogram. D. 75 mg. Answer: B. For refractory VF/pulseless VT, the recommended first dose is 300 mg 4/IO bolus. A second dose of 150 mg may be given if needed. What is the recommended energy for the first synchronized cardioversion of unstable atrial fibrillation? A. 100 J. B. 50 J. C. 150 J. D. 200 J. Answer: A. ACLS guidelines recommend starting synchronized cardioversion of unstable atrial fibrillation at 100 J biphasic. If unsuccessful, higher energy levels are used. Lower energy, 50 J, is more suitable for atrial flutter or SVT. During CPR, a patient develops torsades de pointes. What is the drug of choice? A. Epinephrine. B. Lidocaine. C. Amiodarone. D. Magnesium sulfate. Answer: D. Magnesium sulfate is the treatment of choice for torsades de pointes because it stabilizes the cardiac membrane and prevents further twisting of the points, even in patients with normal magnesium levels. Which is the most reliable indicator that chest compressions are generating adequate circulation? A. Palpable carotid pulse during compressions. B. EtCO2 greater than or equal to 20 mm of mercury. C. Chest wall recoil after compressions. D. SpO2 greater than or equal to 95% during compressions. Answer: B. End-tidal CO2 greater than or equal to 20 mm of mercury is a strong predictor of good perfusion and high-quality chest compressions. Palpating a pulse is unreliable during compressions, and SpO2 readings are delayed. A patient in cardiac arrest has a known history of opioid overdose. What should be given in addition to standard ACLS measures? A. Atropine 4. B. Sodium bicarbonate 4. C. Calcium chloride 4. D. Naloxone 4/IN. Answer: D. In suspected opioid-associated arrest, naloxone should be administered promptly, along with standard ACLS care, to reverse respiratory depression and restore ventilation. When using a bag mask device during CPR, what is the most important factor to ensure effective ventilation? A. Using the largest bag available. B. Delivering breaths as rapidly as possible. C. Maintaining a tight mask seal. D. Hyperventilating to reduce CO2. Answer: C. An effective mask seal ensures air reaches the lungs and not the stomach. Excessive rate or volume can cause gastric inflation and decreased cardiac output. Controlled, steady breaths are key. Which of the following is considered a shockable rhythm in ACLS? A. Pulseless electrical activity. B. Asystole. C. Ventricular fibrillation. D. Sinus bradycardia. Answer: C. Only ventricular fibrillation and pulseless ventricular tachycardia are shockable rhythms. Asystole and PA are treated with CPR, epinephrine, and addressing reversible causes. After ROSC, a patient remains hypotensive despite fluids. What is the recommended first-line vasopressor? A. Dopamine infusion. B. Norepinephrine infusion. C. Phenylephrine bolus. D. Isoproterenol infusion. Answer: B. Norepinephrine is the preferred vasopressor for post-ROSC hypotension as it increases systemic vascular resistance while maintaining perfusion. Dopamine may be used as an alternative, but norepinephrine is more effective and safer. Which step is most critical in the chain of survival for out-of-hospital cardiac arrest? A. Early drug administration. B. Early recognition and EMS activation. C. Early 4/IO access. D. Rapid intubation by paramedics. Answer: B. The first link in the chain of survival is early recognition of cardiac arrest and activation of EMS. Without recognition and rapid response, later interventions are delayed and outcomes decline. Which of the following is not a reversible cause of cardiac arrest? A. Hypothermia. B. Hypokalemia. C. Hyperglycemia. D. Tension pneumothorax. Answer: C. The ACLS reversible causes include the H's and T's: hypovolemia, hypoxia, hydrogen ion imbalance, hypo-/hyperkalemia, hypothermia, tension pneumothorax, tamponade, toxins, thrombosis. Hyperglycemia is not an immediate cause of cardiac arrest. In ACLS, when is it appropriate to use sodium bicarbonate? A. For all prolonged arrests. B. In hyperkalemia or tricyclic antidepressant overdose. C. As an alternative to epinephrine. D. During PA without known cause. Answer: B. Sodium bicarbonate is not recommended routinely. It is reserved for specific cases like hyperkalemia, tricyclic antidepressant toxicity, or severe metabolic acidosis where it corrects life-threatening imbalances. Which action improves coronary perfusion pressure during CPR? A. Faster compression rate, greater than 150 per minute. B. Full chest recoil after each compression. C. Delivering higher tidal volumes. D. Stopping compressions to check carotid pulse frequently. Answer: B. Complete chest recoil allows venous return and improves coronary perfusion. Overly fast rates, excessive ventilation, and frequent interruptions decrease effectiveness of CPR. When delivering synchronized cardioversion, which phase of the cardiac cycle must be avoided? A. P-wave. B. QRS complex. C. T-wave. D. PR interval. Answer: C. Delivering a shock during the T-wave, ventricular repolarization, may induce ventricular fibrillation. Synchronized cardioversion ensures the shock is delivered during the R-wave instead. In adult CPR, what is the recommended compression depth? A. At least 1 inch. B. At least 2 inches, 5 centimeters. C. At least 3 inches, 8 centimeters. D. Approximately 1.5 inches. Answer: B. Chest compressions should be at least 2 inches, 5 centimeters, deep but not more than 2.4 inches, 6 centimeters. This depth provides adequate perfusion without causing excessive injury. Which of the following is the primary purpose of epinephrine in cardiac arrest? A. Correct arrhythmias. B. Increase myocardial oxygen demand. C. Improve coronary and cerebral perfusion. D. Normalize potassium levels. Answer: C. Epinephrine is a potent vasoconstrictor that increases aortic diastolic pressure, thereby improving coronary and cerebral blood flow during compressions. It does not directly correct arrhythmias. Which airway intervention provides the highest level of protection against aspiration? A. Oropharyngeal airway. B. Nasopharyngeal airway. C. Bag mask ventilation. D. Endotracheal intubation. Answer: D. The endotracheal tube seals the trachea and protects against gastric aspiration, while basic airway adjuncts and bag mask devices do not provide definitive airway protection. What is the recommended ventilation rate for a patient with an advanced airway in place during CPR? A. 6 breaths per minute. B. 8 to 10 breaths per minute. C. 15 breaths per minute. D. 20 breaths per minute. Answer: B. With an advanced airway, compressions are continuous and breaths are delivered asynchronously at 8 to 10 per minute, 1 every 6 to 8 seconds. Higher rates cause hyperventilation and decreased venous return. Which arrhythmia is most often mistaken for asystole on the monitor? A. Ventricular fibrillation. B. Pulseless VT. C. Fine atrial fibrillation. D. Sinus arrest. Answer: A. Very fine ventricular fibrillation may appear as asystole on a poorly tuned or low-gain monitor. Always confirm by checking another lead before diagnosing true asystole. Which ACLS intervention has the greatest impact on survival in VF/VT arrest? A. Early 4 access. B. Early administration of amiodarone. C. High-quality CPR and early defibrillation. D. Advanced airway placement. Answer: C. The combination of early defibrillation and uninterrupted high-quality compressions remains the single most important determinant of survival in VF/VT cardiac arrest. During CPR, when should rhythm checks be performed? A. Every 30 seconds. B. Every 1 minute. C. Every 2 minutes. D. Only after 5 drug doses. Answer: C. Rhythm checks are performed every 2 minutes to minimize interruptions in compressions. Each check should last less than 10 seconds. What is the most reliable indicator of ROSC during CPR? A. Rise in EtCO2. B. Increase in SpO2. C. Palpable carotid pulse only. D. Chest wall movement. Answer: A. A sudden sustained rise in EtCO2 is the earliest and most reliable indicator of return of spontaneous circulation, often before a pulse can be palpated. What is the maximum dose of atropine recommended for symptomatic bradycardia? A. 0.5 mg. B. 1 mg. C. 3 mg. D. 5 mg. Answer: C. The recommended atropine dose is 0.5 mg for every 3 to 5 minutes as needed, up to a maximum of 3 mg. Beyond this, pacing or other interventions are required. Which rhythm is most associated with sudden cardiac death in adults? A. Asystole. B. Ventricular fibrillation. C. First-degree AV block. D. Sinus bradycardia. Answer: B. Ventricular fibrillation is the leading rhythm in sudden cardiac arrest. Rapid defibrillation is essential for survival. What is the first drug to administer in a pulseless electrical activity, PA, arrest? A. Amiodarone. B. Epinephrine. C. Atropine. D. Lidocaine. Answer: B. Epinephrine 1 mg 4/IO every 3 to 5 minutes is the first-line drug for PA and asystole. Antiarrhythmics like amiodarone have no role in PA. What should rescuers do if they are unsure whether a rhythm is asystole or fine VF? A. Treat as asystole and continue CPR. B. Defibrillate immediately. C. Administer atropine. D. Stop compressions and wait for clarification. Answer: A. If unsure whether the rhythm is asystole or fine VF, treat as asystole and continue CPR to maintain circulation until the rhythm is clearer. Defibrillation is delayed until a shockable rhythm is confirmed. What is the first-line drug for symptomatic supraventricular tachycardia in a stable patient? A. Adenosine. B. Amiodarone. C. Diltiazem. D. Epinephrine. Answer: A. In stable SVT, adenosine is the first-line drug because it interrupts reentrant conduction through the AV node and often restores sinus rhythm rapidly. Which of the following is a contraindication to using adenosine? A. Atrial flutter. B. WBW with atrial fibrillation. C. Sinus tachycardia. D. SVT with narrow complex. Answer: B. Adenosine should not be used in WBW with atrial fibrillation because it can increase conduction through the accessory pathway, precipitating VF. In pediatric advanced airway management, which technique is emphasized most to prevent gastric inflation? A. High tidal volume. B. Excessive oxygen flow. C. Rapid continuous breaths. D. Slow gentle ventilation. Answer: B. Slow, gentle ventilation prevents gastric inflation, which can compromise lung expansion and circulation. This principle applies in adults as well. What is the recommended compression rate for adult CPR in ACLS? A. 80-100/min. B. 100-120/min. C. 120-140/min. D. 140-160/min. Answer: B. The correct compression rate is 100 to 120 per minute. Too slow reduces perfusion, too fast reduces depth and coronary filling. In post-arrest care, which oxygen saturation range is recommended to avoid both hypoxia and hyperoxia? A. 70 to 80%. B. 88 to 92%. C. 94 to 99%. D. 100% continuously. Answer: C. After ROSC, maintaining SpO2 between 94 to 99% avoids hypoxia while preventing hyperoxia, which can increase oxidative stress and worsen neurologic outcomes. What is the correct sequence when using a defibrillator in cardiac arrest? A. Place pads, turn on, charge, clear, shock. B. Turn on, charge, place pads, shock. C. Place pads, charge, shock, then turn on. D. Charge, then decide rhythm. Answer A. The sequence is: place pads correctly, turn on the defibrillator, select the appropriate energy, charge, ensure everyone is clear, and deliver the shock. This ensures patient and rescuer safety.